Continuing our study of nursing care for patients who have central nervous system disorders. This presentation is related to your Davis textbook on chapter 48. Infection is one of the reasons that people can have neurological deficits. As I mentioned in our previous lecture, neurological deficits can be a result of trauma, tumors, disease. We can look at infectious processes as being a major reason too. So some of the reasons or risks for infection would be a patient who has steroid therapy. For instance, perhaps they're taking Solumedrol. Someone who's on chemotherapy. So as we know, our patients that have cancer and they're taking chemotherapy, they are extremely at risk, and we advise them to stay away from large crowds, to social isolate as much as possible. Radiation therapy also increases your patient's risk for infection, and something as simple as just a very malnourished patient also is going to have an increased risk of infection. One of the more common types of inflammation of a brain covering we would call meningitis, and so that can be related to a bacterial infection or a viral infection. Patients recover more quickly and more completely from a viral infection most of the time, but bacterial infections are still looked at as being the most serious. I know in the 70s and 80s, when I was taking care of children, we had more children that were really very, very serious, critically ill children from meningitis with a bacterial infection. We do have some vaccines that will help protect children from that now. So for instance, meningococcal vaccines, and so the outlook is a little bit better for young children these days. If it's bacterial, again, the problem may be that it may be so severe that it actually is fatal. Also that there can be cranial nerve damage from bacterial. Viral, again, viral meningitis does not have as poor of an outcome usually as a bacterial meningitis. Already mentioned this a little bit, but in order to prevent meningitis, we do have vaccines against the pathogens and antimicrobials when there's been previous exposure. Meaning, if someone has been exposed to someone with meningitis, the physician may well order some kind of antimicrobial for them. Meningitis, signs and symptoms are listed here for you. Severe headache, this is really a major symptom, and it may come on very suddenly. High fever, very high fevers. Nuchal rigidity, which is talking about rigidity in the neck. Often you have a patient whose neck is a bit hyperextended and extremely rigid. Photophobia, meaning the sensitivity to light. Nausea and vomiting, a symptom for a whole lot of things, but also can be a problem when there's some kind of neural inflammation. Koenig and Brzezinski signs can be positive. You have an explanation of that in your book, and if the patient has any kind of mental changes, doesn't have to be with meningitis, can be with other things too, we'll call that an encephalopathy. Remember, encepha relating to the brain, and opathy is always talking about a disorder, disease process. What kinds of things are nurses involved in? Certainly nurses are involved in administering antibiotics as ordered by the physician. We're going to give antipyretics also and do the kinds of things nurses normally would do for someone that has a high fever. So a cooling blanket may also be used. Sometimes we put ice bags on the groins, in the armpits. We remove heavy covers. That doesn't mean completely take everything off of your patient. You may still leave a light sheet, but we're going to work to bring down that fever. Analgesics for the pain, and corticosteroids and any kind of anti-inflammatory medication that the physician has ordered. Remember, we're trying to cut down on the inflammation that's happening in the coverings around the brain. Also, family education may be extremely important. This is a very stressful time for family members to see their loved one who has meningitis. There's often a very decreased level of consciousness that might go along with it. Antiemetics to help with the nausea and vomiting. Droplet isolation, so meningococcal droplet isolation is ordered for at least 24 hours until that patient has been on an antimicrobial long enough to keep them from being contagious to other patients. Putting a patient with meningitis in a quiet, dark environment is also important. This can be important in other types of neurological insult also, but a quiet, dark environment will decrease the amount of stimulation, allow that brain to rest and not be so stimulated. Increased intracranial pressure is a concept that I want to be sure you understand really well. We're talking about more pressure within the cranium. The skull, remember, is going to be hard, is going to be a box essentially that the brain is sitting in, and as the brain expands and swells because there's more pressure for whatever kind of reason, it could be trauma. Certainly there can be a cerebrovascular bleed. It can be because of meningitis, right? If there's inflammation, anything that will cause more pressure in the brain, that pressure is exerted against the cranium, against the skull, and if it's greater than normal pressure, it's going to increase the amount of pressure on brain tissue, on neuro tissue, because there's no chance of it expanding past the space that is confined within the skull. A normal pressure is about 0 to 15 millimeters of mercury. We can go in emergency rooms and in intensive care, a patient who may be having a lumbar puncture even, and we can measure the amount of pressure in the cerebral spinal fluid. 0 to 15 millimeters of mercury, remember, is normal. If a patient is coughing, sneezing, if they have arterial pulsations, a change in position can cause an increase in pressure. If we think about positioning, because nurses are very involved often in what kind of positions are we going to place our patients in. Someone with increased intracranial pressure, you often will have a physician that will tell you exactly how many degrees to have that head of the bed elevated. And if many of you remember from looking at hospital beds, you can look underneath the bed and see the number of degrees. Is it going to be 30 degrees, 20 degrees, 15 degrees, 60 degrees? You really can set the head of that bed to stay at that particular level of elevation of the head. Stop and think a minute. What kind of position changes are going to increase the intracranial pressure? It's actually lowering the head. So someone with the head of the bed flat and they have problems with increased intracranial pressure, you are increasing the amount of pressure that's in their head. If you raise their head a bit, and again, normally a neurologist is going to tell us how much, but if you raise their head a bit, then you have decreased the amount of pressure in the brain. So very, very important to follow that order from the physician and to understand that we could cause something disastrous to happen to a patient where we increase the pressure more simply by lowering the level of their head. Some of the causes for increased intracranial pressure would be a brain tumor, intracranial hemorrhage, any kind of trauma to the brain, and the risk, of course, is that there's damage to the brain because of the increased pressure. The neural tissue is injured and dies, and so there is truly a risk of brain damage and death for our patients who have increased intracranial pressure. Signs and symptoms of increased intracranial pressure will be on your exam, so be sure you learn this. One would be this decreased level of consciousness. We already looked at the Glasgow Coma Scale and how we score level of consciousness for a patient, so we will often look at that. Any decreased level of consciousness, though, more confusion, less awareness on the patient, then that can be a sign of increased intracranial pressure. Restlessness can be a sign of increased intracranial pressure, restlessness and irritability. We also look at pupils, and remember early on we taught you how to assess patients by looking at their pupils. We're looking at the level of dilation when you first shine a light in their eye, and then, well, let me back it up a little bit. What is the level of dilation before the eye is exposed to a light? So you're measuring before and after. A pupil that is very dilated, though, or very sluggish, or has no reaction to light, this is a really ominous sign in terms of your patient having more increased intracranial pressure. It's on what? The optic nerve, of course. So we check pupils when we're monitoring patients for signs, symptoms of increased intracranial pressure. Again, this is the kind of thing, as I mentioned before with the Glasgow Coma Scale, nurses really don't do on every single patient that presents to them. Nurses are doing it on patients who have had head injuries, who have already had a decreased level of consciousness. It could be somebody with meningitis. It doesn't have to be a head injury. And people, anybody that we need to monitor for what is their level of consciousness, are we expecting that there's a probability that it could decrease? The late symptoms of increased intracranial pressure are what we might call a Cushing triad. Bradycardia, which is a lower heart rate less than 60, right? Irregular respiration, so your patient won't have these regular effortless respirations that we know are normal. A widening pulse pressure, and I've mentioned it to you before, but for those of you that may have forgotten, the pulse pressure is the difference between the systolic and diastolic pressure. So if you have increased intracranial pressure with a patient, they will have a rise in their systolic pressure. The diastolic pressure generally stays about the same, but the difference between the systolic and the diastolic widens, okay? Another problem that people can have, neurological, is problems with headaches. And there are different kinds of headaches, but let's look at one of the more serious type, which is migraine. And people who have migraine headaches often have what we might call an aura, some kind of a feeling, sensation, even change in vision that they may have before the pain in their head becomes something that they're aware of. Migraines can be hereditary, and they also tend to be more common in women. There are triggers for migraines. It can be hormonal, one of the reasons it may be more common in women. So women who are menstruating may have rather usual time in the month that they may begin to start having migraine headaches as their hormones fluctuate. Certain foods have been known to trigger migraine headaches. Bright lights can trigger migraine headaches. Alcohol is another one, and stress can be another trigger for a migraine headache. What kinds of nursing interventions do we have? We work with our patients to help them identify what are the aggravating factors, what kinds of triggers bring about this migraine. We encourage the use of warm or cold. I think we've talked before when we've studied pain, but if we look at the pain gateway, often if we give the brain a message of heat or cold, it's going to decrease the brain's perception of pain. We use biofeedback sometime, and that's where the patient really does begin to learn how to, let's say, relax. What can they do to have more relaxed breathing, lower blood pressure, have a more steady, normal heart rate, some of these things that can interfere, make a migraine headache worse. Stress reduction, all right? Relaxation exercises if someone has a tension headache. A dark room and rest for migraine, absolutely. One of the best things you can do for your patient if they come in severe pain with a migraine headache, besides giving them medication, actually is to put them in a darkened room where they don't have so much light and just allow for quiet rest and some darkness. Many patients will go home from work with a migraine headache, and what are they going to do? They're going to go home, they're going to lay down, they're going to turn the lights off, they're going to rest, all right? And certainly nurses are always doing teaching on whatever medications we may be giving a patient. Sometimes they are being prescribed medication to prevent a headache, and there are medications out there that work to prevent migraines especially, and patients are taking medications for pain. What we're doing, of course, as you can see, is we're looking very briefly at different kinds of disorders that are neurological, that nurses are caring for patients that have these disorders. I want you to be sure and not go only by this lecture and PowerPoint, but spend the time in your Davis textbook and look at the care plans that are there for patients who have these different diagnoses. What kinds of things are nurses doing to intervene when your patient has nursing problems related to these disorders? Don't forget that, because that's going to be an important part of your test. They're so well written in your textbook. I'm not adding it to this a little bit lengthy 42 slide lecture about neuro disorders. Seizures are the result of abnormal electrical discharges in neurons, and they can be partial or generalized. If they're partial, a patient may have something called an absent seizure, where all they're doing perhaps is just sort of checking out. You see, especially with children, they may have a petit mal kind of seizure that's more of a partial seizure. They're not falling down, they're not jerking around and flexing all their muscles and drooling and that type of thing, which would be a more generalized seizure. They are just sort of losing attention to what is happening. That type is more of an absent seizure or a petite mal seizure. Partial seizures can also be where perhaps the seizing is only in one part of the body, one extremity. So it could be a hand, it could be an arm, it could be a leg. It's just one part of the body that is having an abnormal electrical discharge still begins in the brain, all right? A generalized seizure is more what we would call a grand mal seizure. Well, that person completely loses consciousness. They will fall down if they were standing, and they will have a lot of flexion and extension of the extremities. That can be a little bit harder for nurses to handle, and we'll talk about that in a minute. Sometimes patients do have an aura before they have a seizure, so they know it's going to happen, and so that person should be taught to put themselves in a safe place. We use different kinds of terms to describe seizures. So if we say tonic, we're talking about the rigidity of muscles. If we say clonic, we're talking about this contraction and relaxation of muscles. And when we use the term post-ictal, we're talking about a stage that's after the patient has had a full-blown seizure and they are very drowsy, very lethargic, not really quite what you'd call awake yet, but they're not having any more tonic, clonic kinds of muscle reactions. What kinds of interventions do nurses have for patients who have seizures? One is, of course, we want the number one, almost always, you really have to look at what a high priority safety is. And when you go out and you take your NCLEX exam, that's something I want you to be sure you really remember, because the NCLEX is going to test for, are you going to be a nurse who knows how to keep your patients safe? Are you going to realize what a high priority it is to keep that patient safe? So definitely for someone that's having a seizure, we need to be sure we provide for safety. That means that if they are in a bed, which they often are if they're inpatients, we should have padded side rails. So that they can't bump up against the side rails and cause any kind of injury. We often try and place a patient on their side to help prevent any kind of aspiration in case they would vomit. We really want to maintain a patent airway for our patients. In the old days, we would put in a tongue blade no matter what. Now, we don't necessarily do that because we can cause more injury to teeth, but we are watching to make sure our patients maintain a patent airway. We give anticonvulsants as ordered. So that means while a patient's seizing, they may need to receive an IV push anticonvulsants. And that's going to be an order from a doctor, and it's not going to be something that LVNs are administering. The RN needs to administer it, but you need to know that may well happen. A drug like Ativan IV often can help stop your patient from seizing. If we think about anticonvulsants, we also need to understand, and you need to understand as an LVN, that giving anticonvulsants that are ordered routinely is an extremely important medication for you to keep giving. Give on time. We want to keep the level up so that the patient will not seize. All right, very, very important. So when you see some of these drugs ordered on your MARs, on your medication administration records, make sure that you are working to give them on time. They're going to be a priority medication for you to keep that blood level therapeutic for your patient. You don't want it to drop below therapeutic because then your patient may really seize. Okay, we're going to assess our patient while they're seizing. We're going to be able to describe it. We want to say, is it partial? Is it generalized? Are they having this grand mal seizure? Are they having focal seizures? When did it start? When did it stop? So the length of time of a seizure is also important. And of course, we're going to document that, and that gets reported to the physician. Very rarely are we going to need to start CPR, but it is possible for a patient to have a respiratory arrest if the airway has not been patent during seizure, so we'll start CPR. Let's also go back to this idea we're going to provide for safety. Suppose your patient isn't in a bed with padded side rails. Maybe they have actually fallen to the floor. We can put pillows around that patient. The idea is not to try and restrain the patient. That can cause more damage. Let them seize without us trying to restrain them, but put some pillows around. Make sure that they're not on the floor near something where they can bang up against it and perhaps break a bone or cause a lot of bruising. Safety, extremely important. Statusepilepticus sometimes is the reason that some people wind up with really severe cognitive deficit. Statusepilepticus is talking about a situation where that patient really doesn't stop seizing in a matter of a few minutes, but it continues and continues, all right? These patients can continue seizing for 30 minutes or more. And in that case, one of the main causes actually is if we abruptly stop anticonvulsant medications. So even if a patient is needing to have a physician change their orders a little bit in terms of what anticonvulsant they're going to take, you may see that a physician is really actually weaning them off, not just abruptly stopping an anticonvulsant. This should say something to nurses too about the importance of following through, giving these anticonvulsant medications on time, and not letting this blood level just abruptly drop. Often the result of status epilepticus is irreversible brain damage. So we have adults who had problems with status epilepticus when they were children, and it caused enough brain damage. There was enough length of time that the brain didn't have adequate oxygenation that really there's a real cognitive decline for that patient. The risk of aspiration is high, and in this case, nurses need to realize they need to manage that airway. We can put in artificial airways in order to decrease the risk of aspiration for that patient. Also, we should always have suction nearby. So if you have a patient that is an inpatient and you know they have a history of seizures, you should have suction nearby, and that should be part of the equipment that's available to you in the room. There are several different types of traumatic brain injury. One is a concussion, which is the mildest. Contusion is more epidural hematoma and then a subdural hematoma. A concussion can be looked at a little bit as a bruising in the brain, and a contusion also a bruising in the brain, but it's larger. We used to look at concussions as not being that serious. However, in say the last 10 to 15 years, we realized that patients who have had repeated concussions, there really can be more long-term neurological deficits than we used to realize. Epidural hematoma is exactly what it says. There is a bleed. A hematoma, right, is a collection of blood, a pooling of blood below the epidural layer of the covering of the brain. Subdural, the same type of thing. Subdural hematoma is below the dural lining of the brain. Both of these kinds of hematomas, they're going to take up space. It can happen more rapidly than or not. Subdural hematomas sometimes take a little while before the patient shows any kind of neurological deficit. So you may have someone that hit their head on a cabinet last week, and now they're coming in through the emergency room and they have a decreased level of consciousness, and it's because they have a subdural bleed. Epidural bleeds, sometimes you have a patient who has a short, what we might call lucid interval. They have the head trauma, but then they recover, wake up fairly quickly, and they have a time of real lucidity where they seem to have normal consciousness. But then because it's fairly fast, fairly large bleeds, then this patient also will lose consciousness. Patients who have epidural and subdural hematomas are usually going to need surgery to remove that hematoma, remove the pressure from that pooling of blood. So your neurosurgeon is going to be involved. Treatment for a hematoma as I just mentioned, can very much be surgical to remove that pool of blood. It can be medical in terms of medications that a patient's given, things that we can do to decrease the pressure in the brain. And those patients, surgical or medically treated, often do wind up in intensive care units. Remember I said, if we have a lot of swelling in the brain, we can have a physician that puts in what we would call a ventriculostomy, and that sits there in the ventricles looking at the pressure that's in the brain, and nurses can measure that. When they're in an ICU, they can also drain off a certain amount of cerebrospinal fluid if necessary. I don't want us to spend a lot of time looking at ICU treatment at the level that we are, which is pre-licensure for LVNs, but we want you to realize it can be done. There's some very good diagrams and a good description of some of the intensive care treatment for someone who has hematoma or increased intracranial pressure that is admitted to an ICU. So a little bit into the future, some of you I know want to advance into your into an RN program, and certainly you would learn more there. For us, something to be aware of, and the reason that it's important to be aware of is because it's important for you as an LVN, if you are caring for someone at a level of care lower than an intensive care unit, that you recognize when they're getting into trouble and that there is help and treatment available when they are doctors notified and when the level of care can be changed. One of the saddest things is to see a nurse on a regular med-surg unit or on a long-term care facility, and they are just watching their patient go down the tube, and they're not notifying anybody, they're not intervening on the patient's behalf, and the patient really suffers neurological injury that they didn't need to suffer. Brain tumors can be cause either because it's a primary tumor, it's a primary cancer, or it's secondary. If it's primary, that basically means that is the level of the tumor. It was first within the brain. If it's secondary, that means it's a tumor that is malignant, but perhaps it started somewhere else. Maybe it's a lung tumor that now has lung cancer that's now traveled to the brain. All right. Either way, the symptoms that a patient has are due to compression of the brain tissue because the tumor has infiltrated brain tissue. Some of the symptoms can be headache, visual changes, seizures, hemiparesis, so that on one side that patient has weaker extremities, and a decreased level of consciousness. Spinal disorders are often cases that nurses come into contact with, whether you're working in a clinic or whether you have patients that are inpatient. And there's two types that we want to look at today. One is that a patient can have a herniated disc, or one is that there's really some spinal stenosis. If they have a herniated disc, that means that disc has bulged on out and now is causing pressure at the level of the spine on the nerve root. So your patient's going to have pain. Spinal stenosis, the same thing. The spinal cord is going to be compressed. Symptoms of the herniated disc are listed here for you. These can be very distressful for patients. Pain is often the main complaint. It may cause a decrease in mobility because of the pressure on that spinal root. People can have numbness and tingling. We would call that a paresthesia, and so they can have paresthesias in any of the four extremities. They can have weakness and atrophy of muscle groups. If your physician is testing for deep tendon reflexes, that patient may have a loss of some deep tendon reflexes. And it is possible with compression at the level of a spinal root that has to do with bowel or bladder continence, it is possible that your patient may also suffer from bladder or bowel incontinence. Laminectomy is a very frequent surgical procedure that removes a piece of bone on each side of the vertebrae, and the idea is when that's done, then it decreases the pressure on the nerve. Please do take a look. I'm not going to run it while I'm doing the lecture, but you go ahead and look at the video that I have here for you about vertebral laminectomy. I also have two links for you. One is to WebMD, another is about a cervical disc herniation. Please take a look at that too. It should help you understand a little bit more what's really happening for your patient. Symptoms of spinal stenosis: pain in the extremities, weakness in the extremities. Remember, the spinal cord is suffering because of compression. Patients who have spinal surgeries, we think about the nursing care. Again, I want you to look at more than just what I'm telling you in this lecture. I want you to read your book carefully, look at the nursing care plans that are excellent, that are in your Davis textbook. But we want to log roll these clients so that we keep the spine in alignment. So when they first come back to us after having had a spinal surgery, log rolling is extremely important. And I have connected you or linked you here in this lecture to a YouTube video that should show you an example of log rolling. We've talked about this before, but of course, patients who have had any kind of spinal surgery are going to require what we would call neurovascular checks. We're going to check extremities that are affected, and we're going to check the neuro and the vascular status. So what are we looking at? Color, warmth. We want warmth, remember. Cold is not good. Warmth is good. A nice warm live body part, that is getting good circulation. We're checking for sensation. We're checking for movement. Can that patient move it? Move their toes, move their leg, whatever it may be that's distal to the area that we're concerned about. And do they have good pulses? So we're going to palpate pulses. So memorize this really well. We're checking for color, warmth, sensation, movement, pulses when we're doing neurovascular checks. And it's not unusual for a physician to order neurovascular checks to be done every hour, every 2 hours, whatever that surgeon wants. In order to understand a little bit more about spinal cord injuries, we need to recognize that the level of injury is going to really determine the neurological deficit that we find in that patient. Trauma is often a cause for spinal cord injury. C3 means cervical. 3 is the third vertebrae. If there is injury at the level of C3 or above, it really usually is quite fatal. If you have a patient with an injury of C4 or C5, they're going to require ventilator support because it's going to affect the innervation of respiratory muscles. Sometimes some of you have asked me this question, so I made sure I included it in this lecture. But we want to understand paresis and plegia. So sometimes we have a patient that, let's say they have hemiparesis or hemiplegia, or we'll say they're quadriplegic. And what does that mean? If paresis is the terminology that's used for the ending of the word, then it means that patient has weakness in those extremities. If it's a hemiparesis, that means 1/2 of the extremities, and at that point we're looking at either the right or left upper and lower extremity. If we're saying that the patient has hemiplegia, then we're not saying that's just weakness. We're saying there's a real paralysis of those extremities. So if it's a hemiplegia, the patient has paralysis on the right or left upper and lower extremities. If we say they have quadriplegia, that patient is paralyzed in all 4 extremities. Something that's really important for nurses to understand and be aware of is this condition that can happen when people have spinal injuries, and it's called spinal shock or neurogenic shock. It really is an emergency condition for your patient. So top priority, if you have a group of patients to care for, once you recognize someone is having a problem with spinal shock. Sympathetic nerve dysfunction is really what is happening, and I have listed for you here what are some of the signs and symptoms. So vasodilation, bradycardia, hypothermia, they can lose reflexes below the level of injury, and also there may be urinary and fecal retention. Complications of spinal injury would make a lot of sense, right? That it's going to, the patient, if they have problems with immobility, they're going to suffer the hazards of immobility that we've already studied. So your patient, the patient that's a quadriplegic, right? Or someone who is a quadriplegic and they're on a ventilator and need ventilatory support, certainly they're going to be subjected to the risk of pneumonia much more than your mobile patients. They also may have problems with urinary tract infection. They may have problems with constipation. They may have problems with pressure ulcers. Any of the hazards of immobility that we've already studied about certainly can happen to these patients who have spinal cord injuries, and especially the higher the level of spinal cord injury, the higher the risk of there being some kind of respiratory infection. Depression also certainly can set in. We have to look at the psycho-emotional condition of our patients, and when you have severe limitations that a patient is experiencing, limitations in function, depression always can really set in. Substance abuse. Substance abuse can go right along with depression, right? These are major changes usually in people's lives. And often, if we want to think about trauma and spinal cord injuries, often these were people who were very athletic, very active, in their lives before they experience this injury. It's not always the case, but it often is the case that we have a fairly young person who's fairly athletic and really used to a high level of activity, very well coordinated, and they have some type of trauma, diving accidents, for instance, where there's a spinal cord injury, and suddenly this person is fairly immobile and paralyzed for the rest of their life. So depression, substance abuse are also complications. We can look at autonomic dysreflexia too as being a real risk, a real complication. What kinds of problems is the nurse going to identify? Safety, again, is huge. If you have a patient that is not able to keep themselves safe, then the nurse needs to look out for what are the safety risks that patient may have. All the things that we've already learned about fall precautions, for instance, all right? Confusion. Is another one. Now these are the kinds of patients, we're not talking about Alzheimer's or dementia at this point. We're talking about patients who may have have confusion due to their neurological injury. So perfectly acceptable and something we want to do. Go ahead and work to orient that patient. All right, do everything you can to bring that patient awareness back to what's really happening. Okay, where they are, who you are, that type of thing. Imbalanced nutrition. If the patient is having problems with swallowing, for instance, they certainly are at risk for imbalanced nutrition. And caregiver role strain is something that we need to think about with family members who are responsible at home for 24/7 care of a patient who has a severe neurological disability. Let's look a little bit, if we're going to think about what the differences between delirium and dementia. Remember, I just kind of threw out there just a little bit. Patients with dementia, often we're not going to be able to help them reorient if they're severely demented. There's not always a lot we can do. But delirium is another thing. Delirium is looked at as a much more acute state. It happens rather rapidly, it's temporary, and it has a cause that we can treat. So it may be fairly common for elderly patients who are having stress and the stress of illness to experience some delirium. But again, we're going to look at what is the cause. We're not going to think of it in the same way that we would think of a dementia, which is progressive, something that we're not going to actually be able to cure. We're not going to be able to bring the patient back to a normal cognitive state. If it's delirium, with treatment, that patient should be able to. So stress and illness certainly can be a common cause for elderly. Other causes of delirium may be something as simple as an electrolyte imbalance, and we need to look at that. So again, delirium is temporary. Keeping the patient safe is still our top priority, but it is a confusion that we would expect to, once the cause is treated, to be resolved. Sleep deprivation can be another cause for delirium. Parkinson disease, we discussed someone we were in our pharmacology course. It's basically caused because there's a loss of dopamine. It's a movement disorder. The patient has tremors. They have a bradykinesia, which is a slowness of movement. That shouldn't be a new term for you, but in case you forgot, remember bradykinesia, slow, kinesia, movement. Your patient often will show symptoms of that. When they have Parkinson, they may have more rigidity, and so we're talking about muscle rigidity. They may have gait and posture changes. They can develop more of a mask-like facial expression. Swallowing can get to be a problem for these patients. So you want to think about Parkinson's disease. It is a disease related to a loss of normal levels of dopamine, which is a neurotransmitter, and it is a movement disorder. And it's progressive, by the way. Huntington disease is another neurological disease, and it's hereditary. It is progressive. It's degenerative, so the nerves cause a degenerative status for that patient. Cognition and movement are affected. People can become very depressed. We're not going to cure Huntington disease, and so depression and suicide going along with that can be a risk for your patient. Nursing care for patients who have Huntington disease involves medications to minimize the symptoms and prevent complications. Always, 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 we're going to work to keep our patients safe. Remember, you've got more information in your textbook. The lectures that I'm giving you is just to help point out to you what are the more important things for you to pay attention to when you do your reading in your textbook. I'm not covering every single thing in these lectures. Autonomic dysreflexia is a life-threatening condition, and it normally happens when there's spinal cord injuries above T6, T being thoracic, 6 being the 6th thoracic vertebrae. All right, and it impairs the balance between the autonomic nervous system. What are the parts of the autonomic nervous system? Remember, we've got parasympathetic and sympathetic. Bladder distension is a common cause of autonomic dysreflexia. So for this reason, sometimes if your patient is having a problem with autonomic dysreflexia, the emergent intervention that the nurse is going to have is actually to relieve that bladder distension. So make sure that there isn't any kind of obstruction to flow in the Foley catheter that the patient may already have in. Perhaps they also need a straight cath, an in and out cath, to relieve that bladder distension. That could be an emergent intervention for the nurse. What are the symptoms of autonomic dysreflexia, and why is it such a disaster for the patient? They have really high blood pressure, really high. So they're very hypertensive. They have cool skin. They have this pale color. All right, so it's a sympathetic nervous system stimulation to the max. Something we don't really want, don't need. It doesn't fit the situation. Stimulation of the parasympathetic nervous system will usually cause these kinds of problems. So vasodilation, which means a drop in blood pressure, right? Bradycardia, lower heart rates, less than 60. The patient may have some flushing. When we look at their skin color, they may have a very pounding headache because of vasodilation in the head. They may have problems with nasal congestion. I think by now many of you have seen patients who are in what we would call a halo brace. This is to protect the cervical alignment for someone that has experienced some cervical spinal cord trauma. And what we're trying to do, of course, is protect the spinal cord from any kind of misalignment that's been caused. Sometimes there may be a fracture, a cervical fracture. I have here a link for you. Please take a look at it. I'm going to return for just a minute. This is the last slide. Thank you for listening, and good luck with your studying. Be sure to do your reading. Be sure to look at your care plans that delineate the problems people have with different types of neurological disorders. Really concentrate on what are the nursing interventions, because remember, that's part of what you're going to choose when you take your exam. Thank you, and this is the conclusion of a brief review of your Chapter 48.